Hi, my name is Mike Pishvaian. I'm an associate professor in GI medical oncology at Johns Hopkins University School of Medicine. So I'm often asked, what is the value of next generation DNA sequencing for patients with pancreatic cancer? And my answer unequivocally is that next generation sequencing for pancreatic cancer is an absolute must. Next generation sequencing means basically taking either the tumor cell DNA or the germline DNA and amplifying the mutations that can be identified. For patients with germline mutations that predispose them to developing pancreatic cancer, some of these mutations can be identified and they could be very important familial implications and also potentially treatment decisions. We also know that within the tumor, there are many, many more mutations that occur, and these are called somatic mutations, and some of these can also implicate different therapies that we may use. And in fact, the NCCN and ASCO now recommend that all patients with pancreatic cancer, irrespective of their stage of disease, undergo germline and somatic tumor testing to identify inherited syndromes for germline and also potentially actionable biomarkers for somatic therapies as well. About 25% of patients with pancreatic cancer overall harbor these actionable or germline inherited biomarker mutations that can actually impact their care. Most of these mutations are in the DNA damage response and repair pathway, or DDR, and this includes the BRCA genes, which I'll talk about in a second. And then there's about 7 to 10% of mutations that occur in a number of other potentially actionable genes, including the NTRK genes. MSI high status is one biomarker. There can be mutations in ROS and ALK, FGFR, and BRAF. And any of these mutations or fusions can be uncommon to rare, but if they're identified in the tumor, may actually lead to specific therapies. And there are many trials being designed around this now. Now, to get back to the DDR patients, again, about 17% of all pancreatic cancers harbor a DDR mutation. About 6 to 8% overall have either a BRCA1 or BRCA2 mutation. And the BRCA genes and the other DDR genes play a critical role in facilitating the repair of damaged DNA in any cell in the body, and certainly that includes tumor cells. And when there's a mutation in one of these genes, then the cell is less likely to be able to repair the DNA. And so when we intentionally damage DNA, particularly of a cancer cell with chemotherapy, if that cell has an impaired ability to repair damaged DNA, they may very well be more susceptible to chemotherapy. We know patients who have pathogenic or likely pathogenic BRCA1 or BRCA2 mutations are more sensitive to and actually have an improved, at least progression-free survival with platinum-based therapies and with PARP inhibitors. And the BRCA genes and other similar genes leave a certain pattern of DNA damage when a DNA damaging agent is used. And that's what we call BRCAness, where basically there's a similar phenotype to having a BRCA mutation, even if an underlying BRCA1 or 2 gene mutation can't be identified. In truth, many of the BRCAness situations are really just mutations in other genes in the DDR pathway, but there's probably a small subset of patients who have a BRCAness phenotype, and we still just don't know what underlying mutation is leading to that phenotype. We also don't know definitively if those patients will benefit from platinum and PARP inhibitor-based therapy, but this is an area of very active investigation.